Donc le prochain speaker, c'est le docteur Stephane Champiat. Je connais très bien Stéphane puisqu'on a fait nos PhD ensemble à Paris. Moi j'étais avec Gisèle Vogel, lui il était avec Jean-Charles Soria. Pendant son PhD, Stéphane a découvert les hyperprogressions, donc c'est grâce à lui que le phénomène d'hyperprogresseur existe. Et en plus de découvrir les hyperprogresseurs, il a fait une application, un livre à Gustave Roussy, et ça a été vraiment lui qui a mis sur pied tout le programme français là, de toxicité. Après avoir fait ce PhD, il a travaillé dans la phase 1 de Gustave Roussy. But as you know, Gustave Roussy is only number 3 in the world in oncology. So 3 years ago, Stéphane decided to go to number 1 center in the world of oncology. So he's now at MD Anderson as an associate professor. And he is in the phase 1 unit. So of course, he moved beyond the checkpoint, unlike us where we stay at the checkpoint. And now he has a lot of expertise in BiTE. And so today he will tell us about the toxicity of BiTE therapy. Merci beaucoup, Stéphane.
So thank you very much for the great invitation. I'm sorry I wanted to be here, but for personal reason, I was not able to join you guys. But hopefully we'll have opportunity to meet in person very soon. So I will give you this presentation about safety profile of T-cell engager in solid tumors. And I know that, as you can imagine, the safety profile of those agents is overlapping with the safety profile of cellular therapy, but we'll see there is some differences. And of course, my focus will be in solid tumors because this is where I really have an expertise. And so these are my disclosure for this presentation. I have to be fully transparent. I have disclosures with different companies developing T-cell engager in solid tumors. So of course, this may affect the way I present the safety. So I want you to be aware of that when you follow me with this presentation. So this is the plan for this presentation today. Really, the first step is to make sure that you're aware of what are these T-cell engagers, how this works, and based on that, how these can trigger some toxicities. And really then dig into what is the toxicity profile of T-cell engagers. Because I'm sure that if I ask in this room what is the toxicity profile of cell therapy and BiTE, the first word that will come to your mouth will be CRS. And I'm happy to talk about CRS and we'll talk about CRS, but you'll see I want to make sure that we are talking about the same thing because sometimes we're confounding and overlapping many things behind the CRS word. So we'll talk about that. We'll talk about ICANS. We, of course, will discuss about the management and the principle of management of this major toxicity. And then, of course, we'll try to open up on how does this impact our real practice and how do we currently try to predict and or prevent the toxicities associated with these specific T-cell engagers. So just to remind you where these T-cell engager position themselves in the panorama of therapies, immunotherapies for solid cancers. As you know, on the left side, you have all the checkpoints that have been approved for the last years. And so of course, these are checkpoint blockade therapeutics. On the right side, you do have some cellular therapies right now available in solid tumors. And today we'll focus on T-cell engagers, and currently there's 2 T-cell engagers approved in solid tumors by the FDA. One is tebentafusp in 2022, and the other one is tarlatamab in 2024. The T-cell engagers approvals is going, of course, beyond solid tumors, and there are many T-cell engager already approved in hematological malignancies since 2014. So the experience and the expertise of managing safety associated with T-cell engager is not completely new. It started with our hematologist colleagues. However, you'll see we have potentially some specificities with solid tumors. And as you can see, the 2 drugs are approved. Tebentafusp is approved since 2022 in metastatic uveal melanoma, whereas tarlatamab, which is a CD3, DLL3, is approved in small cell lung cancer since 2024. I was personally involved in the development of tarlatamab back in the 2019, and even though I'm not involved in the prescription of tebentafusp, I have been involved in later generation of these compounds. So the principle of bispecific antibodies is really to use the capacity to develop antibodies that can recognize 2 things at the same time, and contrarily to targeting targeted therapies where you can recognize targets on the tumor cells. The principle of T-cell engagers is really to recognize on one side a target on the tumor, on the other side a target on the immune system. So having an immune target and having a tumor target. So just a little bit of knowledge about the activity of those drugs. Tebentafusp is not like a typical antibody because it's actually a drug that recognizes on one side CD3 and on the other side, the GP100 peptide. And so the GP100 peptide is not, like any other protein. It's really a sequence of amino acid presented by a TCR. And so that's why we call tebentafusp a TCR-guided T-cell engager. And so that does mean that in those type of drugs, you need to make sure that the patient has the proper HLA presenting the peptide properly. And therefore, this drug is approved, but it's approved in patients who are HLA-A201 HLA, which does mean that it restricts this drug to patients that are around 30% of Caucasians. So as you can imagine, it's not all the patients that can benefit from this drug. This drug is approved based on benefit, overall survival benefit, even though you see that the response rate is slightly increased, only 9% versus 5%, you have, as you can see, a very clear signal in terms of overall survival. We're not going to talk today about the specific activity profile of those drugs, but as you can imagine, there is some things that are slightly different compared to our checkpoint blockade. I will go through this. The second drug, tarlatamab, is a more classic format of T-cell engager. It's a CD3 DLL3, as you can see on the left. On one side, it's recognizing the immune system through CD3. On the other side, DLL3, which is expressed on small cell and cancer cells. It has an FC domain to adjust the pharmacokinetic of the drug. And as you can see here, this drug was evaluated at 2 different doses in the phase 2 study, 10 versus 100 milligram. And at the end, the phase 2 study actually led to approval based on survival, based on response rate, which was 40% response rate in advanced small cell lung cancer who were previously treated, and with a median duration of response, which is around 1 year. So overall, these results led to approval of these drugs. They're clearly active, whether they are associated with safety issues. So just to give you some background about the mechanism of action, these 2 drugs that are approved are currently targeting on the immune side, the CD3. CD3 is part of the TCR complex. And so the TCR, as you know, is a T-cell receptor recognizing on the tumor cells the peptide presented by MHC. By targeting CD3, those T-cell engagers are able to favor TCR complex assembly and stability and induce activation of the T cells independently on the MHC peptide complex. So that does mean that it bypasses the recognition of the TCR and directly activate the TCR for activating the T cell. So beyond CD3, there are other formats that are called engagers. You have engagers that activate the T cells not through the TCR and CD3, but through other activating receptors such as 4-1BB or CD28. There are other immune cell engagers that are activating NK cells like AKJ2D and KP46 engagers. And aside from that, you have checkpoint blockade that are bispecific or bispecific like PD-1 or PD-L1 VEGF that are in development right now. For the focus of today, we really are focusing on immune T-cell engagers. So it does mean that what I will say today is mostly for engagers that target CD3 and eventually activating co-receptors such as 4-1BB or CD28, because overall the safety profile will be similar. So when these T-cell engagers are binding on one side on the immune cells, on the other side on the tumor cells, what it does, it makes a bridge between those 2 cells with a close proximity. It triggers the T-cell activation and therefore the release of perforin and granzyme. And that would allow serial killing. And so the T cell is potentially able to engage through multiple T cell engager molecule and therefore kill multiple tumor cells independently of the MHC independently of the peptide that are presented by the tumor cells. So it literally recruit um, T cells, no matter their specificity, to kill tumor cell spains of the tumor target. As you can imagine, the activation of the T cell is able to trigger some inflammation and release of cytokines that can lead to specific toxicities. So if we now focus on the immune-related toxicity with cancer treatment, we're all aware of IRE, and that's probably the main topic of the meetings today. However, the immune-related adverse events are not only related to checkpoint blockade, and I think we need to accept now that IREs are not only the side effect of checkpoint blockade, but there are other type of IREs that are cellular therapy or immune cell engager IREs that are not same in terms of presentation, that are not the same mechanism of action, but in the context of T-cell engager or cellular therapy, you may have immune-related adverse events that are related to the cytokine release produced by the T cells or other cells that are involved in the reaction of T-cell engager or cellular therapy. And so I think this is probably my most important slide that I'm presenting here, because it's really try to summarize what are the different toxicity that are seen with T-cell engagers. On the left side, you see that, and the most popular side effects of T-cell engager are the systemic immune effects. So that's true when the T-cell engager trigger a systemic release of cytokines. And I think that it's important to differentiate cytokine release symptoms, and we'll talk about that later on, that can lead to overstimulation, which is called a cytokine storm. And all of that is currently called cytokine release syndrome. Sorry, see, I was so into the symptoms and syndrome, but I didn't correct this. Cytopenia is also part of cytokine-mediated effects, and this can happen usually transiently, independently of the tumor target. Neurological toxicity is also part of the systemic effect of T-cell engagers. And among those neurological toxicity, you have the very famous ICANS, the immune effector cell-associated neurotoxicity syndrome, but there are other neurotoxicities such as headaches, dysgeusia, or tremors that are related to the systemic effect of these type of agents. On the other side, on the right side, you see that there are also localized effects of T-cell engagers, and there are on-target effects. So you do have what we call on-target off-tumor toxicity. So depending on the tumor target that your drug have, you can have effects on normal cells that express this tumor target as well. And so, for example, for tebentafusp, which is targeting GP100 peptides, it's also expressed in the skin, and therefore this is triggering rash, and this is really associated with tebentafusp. For DLL3 T-cell engagers such as tarlatamab, clearly there's a class effect with dysgeusia, so there's probably expression of DLL3 in the testing bed of patients that explain this type of specific toxicity. And for new formats that are in development, such as HER2, there's expression in the lungs, so pulmonary toxicity will be part of those agents. CA TCs are associated with colitis, and PSMA is also associated with xerostomia. So these are really specific to each class of T-cell engagers, and therefore are called on-target of tumor toxicity. Another on-target effect that is on the tumor is called tumor flare reaction. So I know that in checkpoint blockade, we are familiar with pseudo-progression. In T-cell engager, there's a similar effect. And so this is the tumor localized effect, and we'll talk about that later, but clearly it's an on-target effect that is seen and is slightly different compared to pseudo-progression, compared to checkpoint blockade therapeutics. So overall, two main classes of side effects, systemic and localized. Systemic mostly due to the cytokine release, on target either off tumor or on the tumor itself with the tumor flare reaction. So let's dig now into the cytokine release syndrome. So cytokine release syndrome has a definition. It's based on the ASTCT consensus. So ASTCT is the American Society for Transplantation and Cellular Therapy. And it's very important to know that, because that does mean that the people who define CRS at this point are people who are using drugs in hematological malignancies more than in solid tumors. And so the way ASTCT define CRS is a supraphysiologic response following immune therapy that results in the activation and engagement of endogenous or infused T cells and autoimmune effector cells. And signs and symptoms can be progressive, must include fever at the onset, and may include hypotension, capillary leak, hypoxia, and end organ dysfunction. So overall, this ASTCT society has graded this CRS, and this is a grading system that is currently used in clinical trials and in the label of the different approved drugs. And so, as you can see, any CRS has to have fever. So fever only is grade 1. And if patient has some hypotension, that's where you can have a grade 2, grade 3, grade 4, depending of the severity of the hypotension. Grade 2 without requirements of vasopressors, and grade 3 with vasopressors, grade 4 with multiple vasopressors. For hypoxia, the grade 2 is for low flow nasal cannula for grade 2, but if it gets worse, it can get 3, or grade 4 if you require positive pressure or mechanical ventilation. So currently, this is the way we grade, and currently the way we address and manage those patients is really based on this grading system. I like to come back and take some step back about the cytokine release syndrome. I think it's really important that we learn to dissociate the symptoms from the syndrome. And so I'm pushing right now to develop a definition of cytokine release symptoms. And so what are cytokine release symptoms? They're just individual symptoms that are usually transient, and they are resulting from cytokine elevation following a T-cell engager administration. So fever, chills, rash, hypotension when it's transient hypoxia, transient liver enzyme elevation, these are just pharmacodynamic effects that are expected when you engage a T cell to release some cytokine. On the opposite side, cytokine storm is really the uncontrolled and excessive cytokine release leading to systemic hyperinflammatory syndrome with potential for multi-organ dysfunction or failure. So even though currently there is no consensus about this, I'm very happy to push those type of definition because I think it helps us to clarify and to better address those patients and manage them. Oops, sorry. And so if you apply those definitions to the ASTCT grading, technically cytokine release symptoms are just the individual symptoms that we're mentioning here, and cytokine storm is really the grade 3-4 CRS that are the ones that are problematic for us in the clinic, and that needs to be better defined. Because if you talk about CRS for fever, why don't you call that fever, right? I mean, it's kind of interesting for me that we try to CRS everything, even though it's just fever, and many agents in IO right now are giving fever to our patients. So I think that this is something hopefully we'll move on from a more precise definition of what are these reactions and how we better manage those. So cytokine storm or CRS grade 3-4 are really these multi-organ failure that can affect, all these different organs and therefore potentially be lethal. And so, of course, for us in a daily practice, it's really our concern is we want to avoid patient getting to that stage. And also, if they are getting to that stage, we want to be able to be managing them properly to limit the risk of death. And so cytokine storm is not something completely new. It's actually the first time that we identify CRS was called cytokine storm. And it comes from a study, a phase 1 study evaluating a CD28 superagonist antibody. So CD20 is an activating receptor on the T cells. And so at that time, back in 2006, healthy volunteers were treated with this drug, and 6 of them actually developed cytokine storm. And so this is really, hopefully, luckily all of them, survive after that, but all of them at the same time presented the same syndrome. And this is since that stage, that first, we avoid treating in phase 1 all the patients on the same day. And second, that we start learning about the CRS. And as you can see in that paper, they published in New England Journal of Medicine at that time, you really see this peak of cytokine that was associated of the cytokine storm. So if we try to dig into the CRS pathophysiology, so the cytokine release syndrome or cytokine storm, we understand that, we know it very well with cellular therapy, where in cellular therapy with CAR T cells, you provide the effector directly to the patient, and those effectors actually release some cytokines. And there is these cytokines will activate later on macrophages, and these are the macrophages who are producing the interleukin-6. So you're providing directly the effectors that are super loaded, super activated, that trigger a further activation of the macrophage and lead to the production of IL-6. With T-cell engagers, we have to realize that the physiopathology is probably different. And so instead of providing the effectors, you provide the tool that can bind to the effector. And I think this is important because this may explain why the safety profile is slightly different, and we'll talk about that later. But also, it also explains us that we can work on the tool, on the antibody, and try to prevent the cytokine release syndrome by different mechanism. And same thing here, we'll talk about that later in this presentation. And one example to show you that CAR T-cell cellular therapy compared to T-cell engager has a different safety profile is just looking at the frequency of severe cytokine release syndrome or severe neurological toxicity. In this publication, we have analyzed different studies that were reporting CAR T versus T-cell engager. In vivo, of course, there's limits of looking at that because each of them are different situations. You do see clearly that severe CRS or severe neurological toxicity is significantly higher compared to T-cell engagers. And so, of course, this is something that is probably related to the different mechanism of action of these two drugs. When you look at the timing of CRS with cellular therapy, typically you infuse the patient with one dose. Of course, usually those treatments are given once. And you see that the CRS timing is between day 2 and day 7. Whereas the neurological tox is between day 4 and day 17. And so there's very delayed safety profile that you see with cellular therapy that is very different when you treat patients with T-cell engagers. So if you look at, for example, tebentafusp, this TCR-guided T-cell engager targeting GP100 in uveal melanoma, you see that the CRS is not within days, it's within hours after the infusion. So the fever and the cytokine release really happen within the first 2 days, but very early on after the infusion. And actually, there are other toxicities, and we mentioned that this on-target off-tumor toxicity, such as skin toxicity, that comes later on, but a couple days after the infusion. Also, this drug is associated with liver enzyme elevation, and same thing here, this is more delayed. And so you do see that the kinetics is earlier and potentially different than with cellular therapy. And actually, if you go into details with tebentafusp, you see that overall, the drug is, yes, giving some cytokine release syndrome, but if you go dig into the details, you see that it's mostly pyrexia. There is very limited grade 3/4 with tebentafusp, at least in this study. You see it's only 1% of grade 3/4, so cytokine storm is almost very few patients with these treatments. So it's mostly pyrexia, fever, rash, and pruritus that is associated with this drug, and also transaminase elevation, AST elevation. So it's very different to what you would think of if you think only about CRS. If you now look at tarlatamab, you see that tarlatamab has also a kinetic that is different compared to cellular therapy. So with CD3, DLL3, T-cell engager in small cell lung cancer, you see that the fever is mostly within the first days. And because these drugs are given in different step dosing with a higher dose at day 8, you see that the fever is still there for some patients around day 8. Fatigue is very common and long while. And you see that neurological tox in the case of tebentafusp, in tarlatamab, sorry, is not only at the first infusion, but can be later on during the treatment. And later toxicity, such as dysgeusia and neutropenia, is really within 15 days or further that you see those toxicities. So very different kinetics in terms of timing of toxicities. And I think this is an important message here. You see this is different compared to cellular therapy, but you see between tebentafusp and between tarlatamab, there are some clear differences. So whatever we tell you about the safety profile of T-cell engager will be very dependent on the drug itself, on the tumor types that will be treated. And so it's going to be different to have a broad management strategy and a broad frequency of toxicity and type of toxicity, because of course, each T-cell engager may have a different specificities compared to checkpoint blockade. However, what we learn that is common between tebentafusp and tarlatamab is really that the cytokine release is mostly happening within the first infusions. And after that, these risk of developing cytokine storm really decrease in time after infusion. So this is, of course, something that is very typical of most of the T-cell engagers in development as well right now. And one thing that you can realize, and this is data that is not really published for many of those drugs, but it's very important for us in our practice, is to see at cycle 1, day 1, how many patients develop grade 1, grade 2, or grade 3 CRS. And after that, how many of them, what is the percentage that will still develop later CRS or eventually worsen. And of course, that if you realize that many patients are developing grade 1, 2, but at the end, very few of them will have grade 2, grade 3, you can be reassured in your practice to not have to admit everybody and monitor everybody if this frequency is very low. And so this is the type of knowledge that we need to get from the clinical trials to better implement those drugs in our practice later on. And of course, this may vary from one drug to another. So these Sankey diagram are going to be very important to translate whatever we learn in trials into our practice and how we manage them as an in or outpatient. So I'm coming back to my obsession of cytokine release symptoms versus cytokine storm and grade 3 for CRS. Really, I think it's important that we keep in mind that there are cytokine release symptoms, and this is expected, and these are to be monitored, of course. They are specific to the drug. It's a pharmacodynamic signal. Grade 3/4 CRS or cytokine storm is the problem, is the pathological issue. And of course, you want to be able to detect which patients are going to lead to this hemodynamic instability, significant hypoxia, or dysfunction of different organs. And of course, in the CRS grading right now, it's between grade 1, 2 versus grade 3, 4, but this is the big difference. And right now, to be honest with you, many of the T-cell engagers that are approved in solid tumors are mostly, or the vast majority of them, giving only grade 1, 2 cytokine release syndrome. And so at the end of the day, very few patients are developing cytokine storm. It doesn't mean that these drugs are safe. It just means that we need to make sure that we don't overtreat the majority of patients, but also can be reactive and manage properly the patient that will develop cytokine storm. So one word about infusion-related reaction, because of course, when you give a drug to a patient IV, some of these patients may develop IRR. Currently, there is no consensus about the definition of IRR, and I would say, of course, it's usually a syndrome that is associated with an acute onset of symptoms. It's either occurring during the administration of the drug or within, and in my experience, approximately 1 hour following completion of infusion. The point here is really to avoid calling IRR with a patient that developed fever 6 hours after receiving an infusion. For me, an infusion-related reaction is something that is triggered by the infusion itself and can affect the dosing because you may have to hold or you may have to reduce the dose for the patient. And so, the classical symptoms of IRR are well known. It's typically the symptoms of anaphylactoid or anaphylactic reaction. At the same time, you can imagine that patients are treated with a T-cell engager may develop fever, transient hypotension, or transient hypoxia due to the fact that they are developing a cytokine release symptoms. And so, of course, we don't want to have a misunderstanding of what is what, because, of course, you don't want to be confused with something that is a pharmacodynamic effect of your T-cell engager compared to an anaphylactic or anaphylactoid reaction. And so I think the big difference between cytokine release symptoms that are occurring during or right after the infusion, which is usually rare, but still, is usually the rapid onset and the fact that patient doesn't accumulate multiple acute symptoms like you would see in an anaphylactoid reaction. And so in practice, I think that one thing that we can advise is really when patients develop a reaction during the infusion, of course, you want to hold if you're suspecting this to be anaphylactoid or anaphylactic. So these are hypersensitive reaction push you to hold the treatment, at least to have the patient improve. It's always good to dose histamine and tryptase because this can sometimes allow you to make the difference, even though usually you don't have the results before restarting the drug. If the patient responds very well to your antihistamine and holding the drug, you can usually re-challenge, and in both cases at a slower infusion rate. Of course, you want to be very careful because if the patient react again or react even worse, you have to consider this could be an allergy, an anaphylactic reaction. And in both cases, if the reaction is so severe with a patient with significant hypotension, it's not the tocilizumab that's going to help, it's the epinephrine and vasopressor. So in both cases, you have to keep in mind that sometimes, and it's super rare, patient may get allergic to the drug they're receiving. Of course, compared to that, the cytokine release symptoms that occur during or right after infusion are usually mild. Usually they are progressive, not very acute. And in both cases, you're not expecting histamine or tryptase to be increased or not significantly increased. In both cases, you're more in a situation of addressing the symptoms, and eventually, if there's a multiple organ failure, considering this as a treatment specific more than a hypersensitivity reaction. So if you think about a patient that you expose to a T-cell engager, within hours and within days, the different side effects can happen. And so, of course, during the infusion, some patients may have infusion-related reaction. And in those cases, keep in mind this can be anaphylactic or anaphylactic. Within hours and within days, patient may develop cytokine release symptoms, cytokine release syndrome, and cytokine storm. And within days, this patient can develop neurological toxicity. So once again, the acuteness of the symptoms during the infusion is highly suspicious of anaphylactic and anaphylaxis. But most of the time, there's no such infusion-related reaction, and we're not more in a situation of cytokine release symptoms that we need to monitor to avoid patient to worsen to cytokine storm. We mentioned about the on-tumor, on-target effect, the tumor flare reaction. And so this is a phenomenon that is underreported in many of our studies. With my ex-colleagues of Gustave Roussy, we are finishing a paper that should be submitted soon about this phenomenon in our patient treated with T-cell engagers. But overall, tumor flare reaction is a clinical syndrome that is usually transient, site-specific response on the tumor sites. And it's really occurring during or within days following the T-cell engager administration. So with pseudoprogression, usually with checkpoint blockade, you have this phenomenon occurring very progressively, and you usually notice it at the timing of evaluation within months. For tumor flare reaction, it's more acute. And so typically you infuse the patient, and during or right after, the patient complains of significant pain on the tumor lesions, or sometimes there is tumor enlargement. Sometimes they even have compression-related symptoms. And for some patients, especially the one that have some baseline pleural effusion, for example, there will be a new or worsening effusion. And so really this is early after a treatment. It does reflect the immune activation related to the T-cell engager. Of course, it's always challenging to make sure this is not another diagnosis, including true disease progression. But most of the time, these are very transient and reversible, and they can sometimes recur when you restart the T-cell engager again. And so for those patients, you may consider having pre-medication in case they had a significant tumor flare reaction at the first infusion. The management is usually very symptomatic and analgesic, and either thoracentesis or paracentesis if a patient has symptoms. And you may consider giving patient NSAIDs, sometimes low-dose steroids or steroids, and in some rare cases, IL-6, anti-IL-6 receptor therapies to manage those tumor flare reaction if they recur and if they are significant. So let's switch now to ICANS. So ICANS are the syndrome of neurotoxicity associated with immune cell engagers, immune effectors. And so, overall, this is the central nervous system syndrome. And once again, this is happening due to activation or engagement of endogenous or infused T cells. And usually the signs are progressive and may include aphasia, altered levels of consciousness, impairment of cognitive skills, and sometimes, very rarely though, but motor weakness, seizure, and cerebral edema. As I mentioned earlier, there are other neurotoxicity that can happen that are not part of this central nervous system syndrome. But overall, the ASTCT again has made this definition and a grading system. And, this is a grading system. I would say in a daily life practice, you don't need to go into all those details. I think the basics are, is there any aphasia or any impairment of cognitive skills? Yes or no? And is it minor, more significant, severe, or very severe? And this is how they build the I score. And this I score is allowing you to more granularity for the grading. So one side is cognitive skills, confusion, and second part is really level of consciousness. And so if you have a very minor impact on your impact of cognitive skills or consciousness, it's a grade 1. But then, if it becomes more significant, grade 2, grade 3, grade 4. If patient end up having seizure, that's directly a grade 3. Motor findings, that's directly a grade 4. And if there's elevated lumbar pressure, intracranial pressure, or cerebral edema, you're already starting at grade 3 or grade 4. In real life, most of the time, it's a very binary situation. Either the patient has a very minor central nervous system side effects, and so it's a grade 1, or very significant, and then it's a grade 3, 4. And so, of course, this is something we want to be careful. And this is something that if you look at the current approved drugs, is more present with tarlatamab. It's around almost 8 to 10% of the patient with tarlatamab. And with tarlatamab, it tends to happen within 24, 48 hours after the first, the second, or the third infusion. So that does require more additional monitoring in those patients in clinical practice to make sure that you don't have patients that go home with a significant neurological impairment. So I know that we're rushing in terms of time, but let me give you some of the main principles of management of this cytokine release syndrome or cytokine storm and neurological toxicity. Currently, there is no major consensus for T-cell engager in solid tumors around the management of CRS of ICANS. There is, and I will share with you the NCCN guidelines that are currently up to date for this, but it's up to date for what we know for now, and there is no, I would say, scientific community agreement on how we should manage, and I will share with you all the different strategies. So really, one thing you have to keep in mind is the management really depends on the drug you're using, because each drug may have a very different safety profile. And as you have seen earlier, if you use a CAR-T versus tarlatamab versus tebentafusp, the risk is not exactly the same, and therefore you should not treat all of the patients the same way with a different drug. So, of course, I will highly suggest you to follow the guidelines of the label of these drugs when you are implementing these therapeutics in your practice and managing patients. I think the first thing is to make sure you identify the symptoms. And so it's important that these patients are monitored for their vital signs when you treat them for the first infusions and after the first hours, monitor for fever, for hypotension, for hypoxia. If there is any suspicion of cytokine release syndrome, to check for other organ dysfunction or failure, liver, kidney, etc. Same thing to have some evaluation of neurological status. So you don't need to do a very detailed evaluation. It's very easy to evaluate if your patient is confused, yes, no, if there's any impairment of basic cognitive skills. So you don't need to have a systematic grading of the I-score for all of your patient every day, but at least have some minor discussion with the patient to make sure that neurological the patient is okay. Of course, depending on the symptoms you identify, you may grade it based on the current consensus, which is the STCT criteria. And based on that, you may have to address the side effects and adjust your monitoring strategy based on the severity of the symptoms. And I think that, of course, with a patient that's doing well without any issues, you don't need to monitor the patient every hour. But if the patient starts developing some symptoms, you may want to increase that monitoring strategy, including the check of labs if the patient has significant clinical reaction. The different measures are used to address those toxicities. Of course, symptomatic with antipyretics, IV fluids for hemodynamic support, but in case of more severe, vasopressors or oxygen is needed. Anti-seizure prophylaxis is discussed in some situations with neurological tox. And beyond that, other supportive therapies. It's very important that you have in mind that you may have to escalate the care to intensive care unit if the patient is getting worse. And of course, in that case, discuss with intensive care unit specialists to manage the patient properly. Currently, the treatment that are used is either methylprednisolone or dexamethasone. And depending on the severity, the dose can vary and the schedule can vary. Tocilizumab is usually used every 8 hours at 8 milligrams per kg, maximum 3 doses per 24 hours. As it is not expected to cross the blood-brain barrier, that's the reason why for ICANS, currently the primary treatment is usually the use of steroids. But you have to realize there is no consensus for CRS management. Some centers will use tocilizumab for prolonged grade 1. Some centers will use tocilizumab as soon as the patient presents grade 2 CRS. For grade 3-4, there's a strong debate whether you should start steroids first or tocilizumab first, or whether you should start with both at the same time. Same thing about if the patient is not responding to your first-line treatment, should you repeat toci or should you repeat steroids, or should you switch or add tocilizumab? And same thing for severe toxicity, discussion of using high-dose bolus methylprednisolone, 500 milligram, 1,000, or whether you use it for grade 4, non-responding grade 3, or ICANS. So currently, there is no consensus about that. But this is really something that you need to define in your own center when you implement those therapeutics. Pre-medication and post-medication, so adaptation of the next dosing is same thing. Usually it's written in the label, but overall, I would say that most of the time, if the patient has minor CRS, you can resume at the same dose. If the patient are more significant, grade 2, grade 3, in those cases, usually you reduce at a lower dose. And eventually, if it's a more significant reaction, you permanently discontinue the T-cell engager. Pre-medication so far has been using either hydration, higher dose steroids, or tocilizumab. And you can also consider post-medication for patients that may develop later CRS after the infusion. All of that, of course, has to be adjusted based on the monitoring and hospitalization that will be required if the patient still had a reaction of the previous infusion, to make sure that the patient is not going to recur with a significant CRS after the second infusion. I know I'm running late, so let me go for more significant slides, and I will be happy to share those slides. One thing I wanted to share with you is currently, and so these are systematically guidance, the implementation of those drugs. So I think that overall, whether the treatment should be initiated in specialist centers, this really depends of your experience. So I would say the first infusion on patient, at least get some expertise from other centers that are more specialized to learn how to implement those treatments in your practice, and make sure that you have the capacity to have patient admitted in ICU one way or the other in case patient develop more significant CRS. There is a high need to make sure that your staff, your patients, your care structure is educated about these type of toxicities. And once again, it's not a matter of stressing everybody. It's not everybody is going to have a grade 3-4 CRS. It's a very minor proportion of the patient. However, you need to make sure that everybody knows this and know how to behave and react with those patients in case they start developing more significant tox. Of course, you want to make sure you know how is the patient at baseline, and you want to make sure that if the patient is frail, you are more careful when you expose them with these type of drugs. Currently, there is no risk factors clearly identified in solid tumors. In hematological malignancies, we know that, for example, the tumor burden is associated with higher risk of CRS. In solid tumors, so far, it's not clear. So you could consider this as a factor, but at this point, it's not proven. The level of cytokine at baseline and on treatment, same thing here. It's not clear whether this is associated with cytokine storm or not. So I would say this is not something you should use as a marker at this point. One thing that you can keep in mind, though, is that patients with pleural effusion or ascites at baseline are at higher risk to develop tumor flare-up reaction. And so be aware of that in those patients to make sure that in case you address this properly in coming days after the infusion. Usually when you start the infusion of those drugs, you want to make sure you start it as early as possible in the morning, because usually those CRS symptoms occur within 4 to 6 hours after infusion. So if you start later in the day, then it's going to happen during the night shift. If the night shift is not as well educated, then they may be stressing out as soon as the patient develops fever. And so you don't want to over-treat those patients, or you don't want to under-treat them. So you want to make sure that at least it's happening during the day as much as possible. And if not, you educate the night shift about how you want to manage those patients. When you start those treatments, you want to make sure you have tocilizumab available in your pharmacy, and even better, next to the patient bed in case patient have severe reaction. Because that's true that if the patient has severe reaction, you don't want to wait an hour to give the patient tocilizumab. And so that's where, as very practical guidance, I would say that no matter what, if you are worried about the patient, don't wait for the tocilizumab, start the steroids. At least you are doing something instead of waiting for the tocilizumab to be given to patient. But it's always a good thing to have tocilizumab ready to be given in case the patient develops severe reaction. Of course, keep in mind that if the patient does a reaction, you want to adapt for the future infusion, the pre-medication or the post-medication. And this is something that we tend to forget because we say, oh, he's doing better now, but you have to realize that it will require some adaptation for future infusions. Key point is whether you can switch this patient as an outpatient, yes or no. So each drug may have their own specificities, but overall, this is usually mentioned in the label of the patient, and usually it's after reaching the target dose and if the patient has minimal cytokine release at the last infusion. So I need to conclude, so I'm not going to spend too much time on that. Let me go. I had too many slides, and I'm sorry, as usual, I'm not good at that. Let me conclude with my final slide, which is this one. Sorry, going too far. Up. Là. So just to conclude about the management of these toxicities, you have seen that we have specificities related to the drug that affect the safety profile of these drugs, that the physiopathology may be different from cellular to T-cell engager in solid tumors. What is very important is to learn from the data that we have in clinical studies. What is the frequency of grade 3/4 CRS in the phase 1, 2, 3 clinical trials? What is the frequency of hypertension? What is the frequency of hypoxia? What is the frequency of TOCI use? Because right now, if you look at that for tarlatamab and tebentafusp, you will see it's very, very low. So it's not the same thing implementing a T-cell engager in solid tumors compared to implementing a cellular therapy. Each center may have different experience. It's very important to build that experience, grow that experience, learn from others to make sure that you know how you want to manage those patients in your own institution. And of course, after that is to adjust your strategy to manage those patients based on the risk factors that you may identify or the frailty of the patient and the way your organization is set up. And depending on how the patient is doing before the first infusion or after following infusion, that you would reassess progressively after each infusion. So all of that would lead to a personalized and adaptive approach of CRS management. And I hope, and I'm sorry I went too far and too long, but I hope that this will give you some clue to help you use these drugs and manage your patient nicely in your practice in the coming years. Thank you very much for your attention.